Welcome, folks. Today we are discussing a study on surgical strategies for chest wall reconstruction, specifically comparing approaches for patients needing this procedure after cardiopulmonary resuscitation, CPR, versus those needing it after trauma.
Interesting. What were the main findings of this research?
The study compared two groups: 29 patients who required chest wall reconstruction, CWR, after CPR, and 36 patients who needed it after trauma. They looked at several key factors, including ICU stay, time to surgery, ventilation duration, and mortality.
And what were the significant differences between the two groups?
Several key differences emerged. First, the CPR group was significantly older than the trauma group, 69 versus 58 years old. Second, the time from injury to surgery was much longer for the CPR group, 1676 days versus 411 days. This is likely due to the need for the patients to stabilize medically before undergoing surgery. Third, the CPR group had significantly longer ICU stays and ventilation times. Their average ICU stay was 45 days compared to 30 days for the trauma group, and their average ventilation time was 593 hours versus 188 hours for the trauma group. Finally, the hospital mortality rate was higher in the CPR group, 20.7%, versus 5.6%.
That's a substantial difference in mortality rates. What about the surgical technique itself? Was there a standard approach used?
Yes, the study focused on a specific surgical technique: plate osteosynthesis of the sternum combined with bilateral transsternal fixation of the fourth or fifth rib. This was consistently applied to the CPR patients. For trauma patients, the approach varied depending on the location and extent of the injuries.
So, the surgical technique for the CPR patients was standardized, but the outcomes were still significantly worse. Does the study offer any explanation for this?
Yes, the study highlights that the underlying medical condition requiring CPR often presents a significant obstacle to extubation and recovery. Even with successful CWR, the patients still need to overcome the initial medical crisis that led to the CPR. The study emphasizes the importance of a careful, interdisciplinary approach to managing these patients, considering cardiovascular status, neurological outcome, and infection control before surgery. They even developed an algorithm to guide decision-making in these complex cases.
I see. So, the longer recovery times and higher mortality aren't solely attributable to the chest wall injury itself, but also to the pre-existing medical conditions. That's a crucial distinction.
Exactly. The study emphasizes that while early surgical intervention is beneficial for chest wall instability, the overall clinical picture in post-CPR patients is far more complex. The algorithm they developed helps to ensure that patients are medically stable enough to tolerate the surgery and that the procedure is timed appropriately.
What are the limitations of this study? It sounds like a retrospective analysis, right?
Yes, it was a single-center retrospective study. This limits the generalizability of the findings. Also, the comparison between the trauma and CPR groups is limited by the fact that the underlying medical conditions are vastly different. The study acknowledges the need for larger, prospective, randomized, multi-center trials to confirm these findings.
So, while the results are compelling, more research is needed to definitively establish the optimal surgical strategy and timing for chest wall reconstruction in post-CPR patients.
Precisely. The study provides valuable insights and highlights the need for a more nuanced approach to managing these complex patients. But further research is crucial to refine our understanding and improve patient outcomes. Thank you for listening, folks. We hope you found this discussion informative. Goodbye.